medications from, the anti-inflammatory treatments such as interferons. But there's also some recent observations that may suggest that migraines may suggest that your MS is actually active at that moment. There's more research that needs to be done, but migraines, yes, they are very common, but we also have to remember they're very common overall in the female population. The treatment of the migraine for MS is very similar to if you do not have MS, and so they do need to be treated. So regardless of the etiology, the treatment would be very similar, or even just changing your treatment for treating MS, getting rid of the interferon.
Okay, we're starting to run out of time, so let's speed it up, get a little more lightning round going, and
this is related to stem cells. I think you ought to realize that in MS lesions, there are lots of stem cells, and stem cells that could repair the nervous system, but they don't. So there's been a major focus and current research on what can be done to make our own stem cells do the repair work. And there is actually an antibody called anti-LINGO, which is being tested, and LINGO is one of the inhibitors of this differentiation. Now, we think that obviously, with some prejudice, that there is great potential in stem cells. But the issues really are that right now, the mesenchymal stem cells, bone marrow stem cells, there's very little evidence that they actually get into the nervous system, but they do produce changes in the blood-brain barrier, and they do produce immunosuppression, and therefore the patients do benefit from this process. We really have to let the 50 or so international studies that are going on be completed before we come to a conclusion that this is a superior methodology and whether it is something that is worth the cost. Now, the other is the iPS cells, which are taking the patient's skin, treating them with a certain number of genes, and changing that skin of that patient into an embryonic stem cell. And you could make neurons that way and oligodendrocytes. Right now, the major use of this is to study the disease, which obviously that patient's disease. The question is, clearly that will be useful to make stem cells out of that, because those will not be rejected because they're coming from the patient. So this is a very, very fertile field, and actually somebody won a Nobel Prize for this a couple of years ago. And I think that without question, we are just scratching the surface of stem cell treatments, and the big issue is repair. The Canadians have just finished a 10-year study which shows that patients after 4 or 5 years of bone marrow transplantations with immunosuppression have no new gadolinium-enhancing lesions over a 5-year period, and that patients are doing well. Now, the question again is that from the fact that they were primed with an immunosuppressive agent before they got the bone marrow? But we use autologous bone marrow now, so a lot of that does not have to be done. So quite clearly, this is an open field. There are studies going on in this country with mesenchymal stem cells. There's actually a very nice study sponsored by the NIH at the Cleveland Clinic, which is going on. And there has been a study at Northwestern that's now in its 5th year where we've sent patients for transplantation. So the issues really is that we don't know yet, but we think this is a very fertile field.
So we're going to continue with the lightning round. We're going to try to answer all the questions we have here unanswered, but very briefly. So I'll take the first one. The first one was about the efficacy of oral medications for relapsing remitting MS. As most trials have been only 2 years, what do we know about that? So this is a good question. All the trials are usually, even if they are only 2 years in duration, they are continuing with an open label of the medication medication. So most patients, even the patients who are on placebo, will go on the medication under study. So we start having data up to 5 years for a medication like Gilenya, for example, because patients have been monitored for a longer period of time. But this is still a small number of patients because these were the patients who were in the trials. So all these medications that are new, we have to be careful when we use them in terms of making sure they are really safe for patients.
I have a couple of quick questions. One is about overactive thyroid and what to do about it. So there are ways that doctors can deliver radioactive chemicals to the thyroid to knock out its function, and then you replace it with artificial thyroid hormone to help regulate the level. So if you're high thyroid and you're not responding to the treatment that you're on, you can actually have this radioactive cocktail and then take thyroid replacement. So,
I have a question. That was my question.
yes.
Does your thyroid bounce back without having to kill your thyroid? Like, I'm trying to avoid killing it.
Well, typically, the doctors will try to treat you for a year with propylthiouracil, and then if it doesn't work, after that, you may need to just wipe it out. There are a lot of questions about bowel problems in MS, and so it's really common in MS, and some of it may be related to spinal cord neurologic dysfunction. There are nerves that control our bowel function, but there is also an increased incidence of other autoimmune diseases. The category that we call inflammatory bowel disease, Crohn's disease, and ulcerative colitis seem to be more common in MS. And so if you're having a lot of bowel problems, and it may be worthwhile seeing a gastroenterologist, having a colonoscopy, and making sure you don't have a second process, because that can sometimes impact on bowel motility.
I might just mention that comorbidities in MS patients occur, and by that I mean they have other autoimmune diseases besides their MS. The one thing I warn my patients about is that if somebody's going to treat them for Crohn's disease or for rheumatoid arthritis, better make certain that those drugs are not going to make their MS worse, and some of the drugs do. So, for instance, all of the monoclonal antibodies that are used in rheumatoid arthritis have been shown to make MS worse.
So my question is, are we concerned about the large impact of the biotech companies that are obviously giving us these these treatments for MS, and are we concerned about research dollars drying up? Well, there is, yes, definitely we are concerned in respect to, the research dollars coming from the federal government, or the support provided to NIH. And as researchers, we are dependent on this money. And foundations like the Nancy Davis Foundation, which is why we're here, is that it definitely provides another avenue. And it's an avenue that where the board of directors is individuals that are, are actually real investigators, researchers that have had or have current NIH support, but also are able to provide us very good feedback and picking the projects that need to be funded. In respect to the large biotech companies, of course, that they are able, they study the drug for 2 years, and maybe there's the follow-up type of studies, but those studies are not enough to give us the real life experience. And so other type of studies are needed to give us that real life experience. Is that, let's say, Tecfidera going to work in that particular type of population with certain specific characteristics? And that, I think, needs to be funded from NIH and eliminate some of the biases. So that's...
There is a lot of work being done to try to individualize treatments for specific diseases. So the major target has been, say, hypertension, in which you try to have an individual therapy and try to know beforehand, by looking at the genome of that particular patient, whether the medicine that we're going to use is going to work, rather than a trial and error. And there are studies like that going on right now in almost all the autoimmune diseases, so that maybe we can identify beforehand who is going to respond to what treatment. And I think that that is not something that necessarily the drug companies are interested in.
I have a question here about Dr. Wall's diet, if you've heard about that. She's a physician who reportedly has MS and was in a wheelchair, very disabled for a number of years, and then cured herself by going on a paleo diet, which is a lot of kale and kidneys and whatnot, and she's supposedly symptom-free. So the nervous system doesn't repair itself that way. So if you have somebody who's been so damaged from MS that they've been in a wheelchair, unable to move normally for a number of years, it's going to require something a lot more powerful than eating kale to do that. So you always have to wonder about, this is miraculous and
So you don't think motor oil would do it?
only if you applied it on her forehead. And we hear about things like this periodically. The person who was in a wheelchair for 5 years and got stung by a bee, and then the next day was up walking around. You have to take those things sound miraculous, and I think that's probably the best description of them. And I don't think the diet that she's selling on her website is a healthy diet. So I recommend people not follow that diet.
I have one question. Can one autoimmune disease beget another? And in this case, there was a question about Ehlers-Danlos, which is not particularly autoimmune. That's a hereditary condition, but generally autoimmune conditions can run together. So you might have an individual who has more than one autoimmune condition, including MS. You might have family members who have not MS, but other autoimmune conditions. So there are shared genes between different autoimmune conditions, lupus, MS, psoriasis. Some of the medicines work for the different conditions. Some of them don't work for some of these different conditions. So there's a lot of shared autoimmunity susceptibility factors, and that's now being clear in research studies.
This is a question related to relapses that might be obvious to a doctor but not to the patient. I think that sometimes it's not obvious to the doctor either. So I think that the key points are that you don't have any fever. It's not 110 degrees out. There is no infection anywhere, and you feel more fatigued, and you have a little bit more clumsiness, and it lasts more than 48 hours. That may well be a mild relapse. Not every relapse has to be treated. Some of them are so mild that we just sort of wait them out, but quite clearly some of them can be very subtle. But the big thing is not to have something else that's making the patient worse that we can take care of, like a bladder infection or flu or something of that sort. And the other, of course, is that the ambient temperature outside is not what we see, say, in the desert, and that is that it's very, very high, because that will make the MS symptoms. It's an electrical disease, and it will make the symptoms worse.
I think that concludes, I'm going to let Nancy conclude the session, but please stick around, and we'll be happy to stay up here and answer any questions you have.
I do have one question here. It says, Nancy Davis, are you still not taking any MS meds? If not, what is your secret? Diet, exercise. You look great. Thank you very much. This will probably make somebody right here not very happy with me, but I guess to tell the truth, when I was diagnosed, there was no drugs on the market at all to help stop the progression of MS, and I went the homeopathic route and take a lot of vitamins, exercise, drink tons of water, never take any drugs, don't smoke, don't drink coffee, don't do anything like that. And I did get better. And when I've had attacks, I've gone to a homeopathic doctor, which they don't want to hear about. But, okay, no, I do too. But I know if I was diagnosed today, there's not a chance that I would not be on one of these medicines. I did get better at a time when there was nothing to choose from whatsoever. So I've continued to do what I'm doing, and it's working really well for me. And I really think a positive attitude, no matter what type of MS you have, is critically important. If you think positive and you make plans for your life and you live every day to its fullest and you don't, sit in bed and feel sorry for yourself every day. You have a much better shot at going out and accomplishing things. If you have a busy life, you should keep your busy life going. And I'm very aware if I'm not feeling well, and I do what's always worked for me. And I think everybody needs to know what to do and to be very proactive and take charge immediately if you can. What works for me might not work for everybody else, so I think it's really important that you know that. But I like what works for me, and I like the homeopathic things, but I know somebody over here is not going to be happy with me.
Let me just say, most of us have patients, particularly if we have enough gray hair, that have had this disease before there were any treatments. And I have patients that have had MS for 40 or 50 years, have never been treated. And they've done well. The problem is we cannot predict that. Someday we might be able to look at someone and say, okay, you're going to be okay if we don't treat you. And the others would say that, well, you need to be treated even though you feel great right now. I have one woman who's now in her 70s who had her first episode when she was 25. Never been treated. I keep seeing her once a year. I've even repeated her MRI to make sure the diagnosis was correct, because I've not been following her for 50 years. But someone did and made the diagnosis. So I think that it's a variable disease. And there are people out there that probably don't need to be treated, but we cannot identify them early on. And until they go sour, we don't want them to go sour. So therefore, we treat everyone.
Is it possible that having 5 pregnancies was protected from the course of the disease, like my mom had six children?
I think it makes you insane in your head. But I don't think it allows you to have any time to be sick. That's all I can say for that.
You don't think it might have been all the hormones, like the hormones in your body, because 6 pregnancies, that would maybe protect them in some way?
I know that I haven't been pregnant my whole life, but I feel like I'm still losing the baby weight. But